We're going to talk about congenital heart defects and acquired um, heart disorders. This is just a review that Ms. Jordan asked me to do with you guys. The two major things that we're going to look at are your congenital heart disease and your acquired heart disorders. Your congenital heart defects. Um, One of the first heart defects that we will look at is ASD. Um, ASD is a congenital heart defect that where you actually have a hole, or it's not always the same size, but you have a hole between the atrium. And this is considered a acyanotic heart defect. And the two groups that we're going to look at for heart defects will be acyanotic and cyanotic, by the way. But a atrial septal defect is a heart defect where you have an abnormal opening between the atria that allows blood from the left atrium to flow into the right atrium. So you have blood flow that goes from the left atrium to the right atrium. And this is the reason why this happens is because the pressures are higher in the left atrium, so it will automatically go to an area of low pressure. So because this left atrial pressure is slightly exceeds the right atrial pressure, blood flows from the left to the right atrium, and this causes an increased flow of oxygenated blood into the right side of the heart. So it's not a cyanotic heart defect, it's a acyanotic heart defect, meaning that you will not see signs of cyanosis like, blue fingertips and, you know, uh, blue areas around the mouth, um, things that indicate decreased oxygen going out to the systemic from the left heart. So the volume is really kind of well tolerated in this right atrium and or and the right ventricle, and it's delivered without much problem until you get the overstretching. So basically, the volume is well tolerated by the right ventricle because it's delivered under lower pressure than with VSD, and we'll talk about VSD in a second. And although there's right atrial and ventricular enlargement with this particular defect, um, cardiac failure is unusual and not and uncomplicated in ASD. You get pulmonary vascular changes usually occur only after several decades if the defect is left unrepaired. But the clinical manifestations of patients may be asymptomatic. They may develop heart failure. There is a characteristic systolic murmur with a fixed split second heart sound. So there may also be a diastolic murmur. So you're basically going to hear either a systolic or a diastolic murmur or both. And the patients are basically are at risk for atrial dysrhythmias. So any type of atrial dysrhythmia caused probably by that right atrial enlargement. And we'll learn about conduction and all that next semester. But anyway, so surgical treatment is usually a surgical patch or closure, which is called a pericardial patch or like a Dacron patch, is done for like a moderate or a large defect. Um, and you'll have they'll open their chest, open repair with cardiopulmonary bypass um, is usually performed before school age. Um, but you can have non-surgical treatment, and that's where you have a closure with a device during cardiac catheterization, and that's when they go in through the femoral artery, or and that's probably becoming more commonplace, and it can be done like outpatient. So very low mortality rate. Um, Next heart defect that we look at is VSD, and this is where you have an abnormal opening between the right and left ventricles, and it's it depends on the location and the size. The size may vary in size from a small pinhole to where there's absolutely a complete absence of the septum, and sometimes that results in a common ventricle. VSDs are frequently associated with other defects. You often see them in a some type of sequelae, but they may be, you'll see a VSD with a pulmonary stenosis or transposition of the great vessels, a PDA, atrial defects, coarctation of the aorta. So if you see a VSD, you're sometimes looking most likely for something else also involved in that. But a VSD, many of them, like 20 to 60% of them, are going to close spontaneously. And spontaneous closure is most likely to occur during the first year in life in children that have small or moderate VSDs. And in this is an acyanotic heart defect where you have the left to right shunt is caused by the flow of blood from the higher pressure left ventricle to the lower pressure right ventricle. So the flow goes this way because the pressure in the left ventricle is higher. And because of the higher pressure within left ventricle and because of the systemic arterial circulation, it offers more resistance in the pulmonary circulation. So the blood flows through the defect into the pulmonary artery. So the increased blood volume ends up getting pumped into the lungs. And this will and may eventually result in like an increased, pulmonary vascular resistance and increased pressure in the right ventricle as a result of this left to right shunting, and pulmonary resistance causes muscle hypertrophy. So what happens is that eventually this muscle will get very hypertrophy, meaning it gets bigger and bigger later on down the road. If the right ventricle is unable to accommodate the increased workload, and the right atrium may also enlarge. So it'll back up into the right atrium. It's going to back up into the lungs. Um, and you might get right atrium enlargement. Okay, so clinical manifestations. Heart failure is common because you will see the back up of blood into the lungs, back up, and you'll see enlargement of the right atrium and some hypertrophy going on in here because of the increased blood coming across from the left ventricle into this right side of the heart because the pressures are lower on that right side and higher on the left. Sometimes you'll see and also with your clinical manifestation, you'll see some like I said, heart failure, and there's a characteristic loud holosystolic murmur, and we hear that at the left sternal border. And this holosystolic means that it's all the way, you hear that murmur all the way through systole. And these patients are at risk for heart failure. So surgical treatment sometimes is palliative. We do pulmonary artery banding, so they'll come in here and band this pulmonary artery, so that the blood isn't back or going forward into the lungs. So this pulmonary artery banding is basically a band around the main pulmonary artery to decrease the pulmonary blood flow that is the result of this blood coming into this right side of the heart. And it can be done in infants, with multiple, or large VSD. But then you could have they may do a complete repair where you have small defects where they're repaired with sutures, or you could do large defects, usually require like that knitted Dacron patch, and they sew it over the opening. And they use cardiopulmonary bypass for both procedures, and so of course the risks that go along with that. What they usually do for this complete repair, where they put the Dacron patch or they suture it, is they go through the right atrium and the tricuspid valve, and so we have to watch out, during those surgeries to make sure that you are looking for complications from that, like conduction disturbances or arrhythmias. Um, but then you have your non-surgical treatments where they do a device closure during cardiac catheterization, and but mostly I've seen those done. It's the research or the reading said they see them in investigational right now for devices for VSD. And the prognosis is pretty good but it depends on the location of the defect, the number of the defects, and of course, the presence of other associated like cardiac defects. So, um, your next defect that we'll talk about is patent ductus arteriosus. Patent ductus arteriosus is basically it's the failure of the fetal, like when you're a fetus, failure of the fetus ductal arteriosus, which is an artery connecting, when you're in the womb, there's an artery connecting the aorta and the aorta and the pulmonary artery. And the reason why it's there is because we bypass the lungs in fetal circulation because the lungs are full of fluid. So there has to be a way to oxygenate the tissue. So this little ductus arteriosus is there for that reason. So basically, it should close within the first weeks of life, because you know, when you take your first breath, come out and you're born and you take your first breath, the pressures reverse in the heart and they become, to where you have more pressure and it forces this to close. So now you have, you know, conditions with patent ductus arteriosus is that the continued patency of this vessel will allow blood to flow from the higher pressure aorta to the lower pressure pulmonary artery, and this will cause like a left to right shunt. And basically, your patho is that the hemodynamic consequences of a PDA depend on the size of the ductus and how much pulmonary vascular resistance there is. So, just to kind of recap, at birth, the resistance in the pulmonary and systemic circulation is almost identical. So that's why it stays open, right? So, the resistance in the aorta and the pulmonary artery are equalized. And so as the systemic pressure, or your blood pressure systemically comes to exceed the pulmonary pressures, right? Blood begins to shunt from the aorta across the duct to the pulmonary artery in a left to right shunt. And like the additional blood is recirculated through the lungs and returned to the left atrium and the left ventricle. And the effect of this altered circulation is this increase on the left side of the heart, increased workload on the left side of the heart. And then you get increased pulmonary congestion, and potentially you could have an increased right ventricular pressure and development of hypertrophy. But it should close, and that's what you're hoping for when they take that first breath, and in the first week of life it starts to close because those pressures reverse. So Your clinical manifestations for this type of for patent ductus arteriosus are patients, they could be asymptomatic or they could show signs of heart failure. And there is a characteristic like machine like murmur, is what they call it, like a machine like murmur. Sounds like a machine almost. And you have a widened pulse pressure and bounding pulses result from and the from this runoff of blood from the aorta to the pulmonary artery. And so your medical management is going to be administration of indomethacin, which is a IV, indomethacin, which is a prostaglandin inhibitor, and it closes the PDA in preterm infants and some newborns. But surgical treatment for a consistent PDA is surgical division or ligation of the patent vessel is performed with a thoracotomy. So they actually go in through, the chest cavity or a thoracotomy, and they take a thoracoscope and into the left side of the chest and place a clip on that ductus. Okay, and then you can have your non-surgical treatment where they use a coil and it basically occludes, and that's done by catheterization, and they'll put like a little coil in there, and it'll occlude that PDA. But if you got a really really large one, it's most likely going to require surgery. But if you and so if especially if you're a preterm or a small, very small infant, you got to go in through that femoral artery, and so you may have to get surgery versus the catheterization. It's a pretty good prognosis with this one too. Um, the next one that we'll talk about in your book is your coarctation of the aorta. And this is like an obstructive defect, and it still is in the acyanotic category. And this is where you have like a localized narrowing in that in the aorta, and where and for infants, it's a localized narrowing near the insertion of the ductus arteriosus, and this results in an increased pressure proximal to the defect. So in infants you'll see head and lower upper or head and increased blood pressures in the head and the upper extremities, and decrease pressure distal to the obstruction, so the body and the lower extremities. So the effect of the narrowing in the aorta is increased pressure proximal to the defect, which is the upper extremities, and decreased pressure distal to it, which is the lower extremities. So your clinical manifestations, the patient could have high blood pressure and bounding pulses in the arms, and weak or absent pulses in cool lower extremities with a lower blood pressure in the lower extremities. You could have heart failure in infants, and some infants with like a really really critical coarctation, very very small diameter. You'll see like a really really rapid hemodynamic deterioration and development of severe acidosis and hypotension because you're not getting any blood flow to the lower extremities. And so a lot of these kids end up on mechanical ventilation, and they end up on some cardiac drugs. And now older children, if they make it to where they're older, they may, if they've got a larger area coarc that is hasn't been detected, they may get dizziness, headaches, fainting, bloody noses from all the hypertension in the upper extreme in the upper part of the body. And these patients are at risk for hypertension. They could rupture the aorta. They could have an aortic aneurysm. They could stroke out. Um, Pretty much your surgical treatment is a surgical repair. Um, Surgical repair is a treatment of choice for infants, younger than 6 months, and for patients with long segment stenosis or like some of these have very, they have other defects that go along with it and complex anatomy stuff. But this long segment stenosis means that the stenosis is it's a pretty significant narrowing for a longer segment of the aorta. Um, the repair is basically by resection of the coarcted portion, and then they do like an end-to-end anastomosis of the aorta, or enlargement of the constricted section using like a graft or a prosthetic material or a portion of the left subclavian artery. They might take part of the subclavian artery and put it in there. But because this defect is outside of the heart and the pericardium, they don't use cardiopulmonary bypass machine. So what you'll see is so you won't have cardiopulmonary bypass machine on this child, and they'll use a thoracotomy. They'll go in through the thorax. Um, with the they suggest, if it's not a rapidly deteriorating, very very small or diameter coarc or a long coarc, to have surgery within the first 2 years of life. Um, and sometimes they can do percutaneous balloon angioplasty, where they go in the heart like in a catheterization, and they'll insert a balloon. And balloon angioplasty is being performed as a primary intervention in coarcs in older infants and children. And like in adolescents, they may even put a stent, um, gets placed in the aorta to maintain patency. Um, but sometimes you'll see these kids will go in, they'll have the balloon angioplasty, and it'll start to restenose, and you see that a lot in young infants. Okay. Right here, this picture right here is um, where you will have sometimes you'll have what is called a ductus arteriosus. I'm sorry, at the ductus arteriosus, you'll have what we call a preductal, which is over here, or a postductal. Um, and we see the postductal most often, and see how the coarc is after the ductus arteriosus, or it can be before the ductus arteriosus. And you'll see this more in infants, okay? Which is the postductal. The next one, heart defect that we'll look at is, if I can get it to move down, is your tetralogy of Fallot. And this is a mixed defect, and many complex cardiac anomalies are in this mixed category, and I think this is the only one we're looking at. Is you know because survival in the postnatal period depends on mixing of blood from the pulmonary and systemic circulations when the heart chambers, hemodynamically, fully saturated systemic blood flow mixes with the desaturated pulmonary blood flow. and causing relative desaturation of the systemic blood flow. Pulmonary congestion occurs because the differences in the pulmonary artery pressures and the aortic pressure favor that pulmonary blood flow. So cardiac output decreases because of the volume because of the volume load on the ventricle. But clinically, these mixed patients, these have a variable picture that combines some degree of desaturation, although cyanosis is not always visible. And so that's why it gets classified in cyanosis. So it's in the cyanotic column, um, because you may or may not see cyanosis, and it's important to remember that, you know, and I believe your book talks a lot about that you're not always going to see cyanosis in congenital, as a clinical sign in congenital heart failure, even though it's classified as a cyanotic, but we do put this one in the cyanotic column, um, because at times you can see cyanosis. So basically, there is a there are certain things that occur with this defect, and one of those is where you have pulmonic stenosis, and then you have a so decreasing the pulmonary blood flow. So the classic form of this tetralogy of Fallot is contains four defects, where you have a VSD, which is a hole between the ventricles. You have a pulmonary stenosis. You have what is called an overriding aorta. Okay, where it's overriding just above the hole between the ventricles. And then you have right ventricular hypertrophy. Let's go over that again. You have a VSD, you have a pulmonary stenosis, a pulmonary valve or pulmonary artery stenosis, and then you have a um, overriding aorta, where the aorta is right above that and it's overriding, and there's a right ventricular hypertrophy. So what does this mean? Basically, the alterations or the changes in hemodynamics vary widely depending on primarily the degree of how tight that pulmonary artery is, but also the size of the VSD. So if the pulmonary artery is tight, it's going to be very, very decreased amount of blood flow to the lungs. And then if you've got a big old VSD, think about that. How much blood is going to start flowing into that right side, causing this hypertrophy of the right ventricle. Um, so so the size of the VSD, the degree of the pulmonary artery constriction, um, and because the VSD is usually in most cases large, pressures may equal in the right and left ventricles eventually, and sometimes the shunt direction depends on the difference between the pulmonary and the systemic vascular resistance. So, do you have a higher blood pressure, or is the pressure in your lungs higher? So, if the pulmonary vascular resistance is higher than the systemic vascular resistance, you're going to see a shunt from right to left. If the systemic vascular resistance is higher than the pulmonary resistance, then the shunt is left to right. So if your pulmonary stenosis, decreases blood flow to the lungs, and consequently the amount of oxygenated blood that returns to the left side of the heart. So depending on the position of the aorta, blood from both ventricles may end up distributed systemically. So that means they'll go this way. Okay. So there's a lot dependent on how big that VSD is and how constricted or how bad is the stenosis in the pulmonary artery. So that's why it's kind of this is a, where you possibly have could have a right to left shunt versus a left to right shunt. Okay, or it could equal out. So your clinical manifestations though is some infants may be acutely cyanotic at birth. Others have a mild cyanosis that progresses over the first year of life as the pulmonary stenosis gets worse. So the degree of your pulmonary stenosis is going to depend on how cyanotic you get, right? There's a characteristic murmur, systolic murmur. There may be acute episodes of cyanosis and hypoxia, which we call blue spells or TET spells, and these anoxic spells occur when the infant's oxygen requirements exceed the blood supply. So if you've got this pulmonary stenosis, pulmonary artery stenosis, there's very, very decreased blood flow to the lungs, and you start increasing activity, yeah, you're going to get a blue kid. So it's you have this requirements that exceed the blood supply. So it's usually during crying or after eating. So you have to be very careful or when you see these kids, if they're crying after eating, they're at risk for loss of consciousness or sudden death after an anoxic spell. They may have a seizure. Anyway, so your palliative shunt is your surgical treatment. And if infants who can't undergo primary repair, a palliative procedure is done to increase the pulmonary blood flow and increase oxygen saturation. So the preferred procedure is what is called a modified Blaylock Taussig shunt operation. And what it does is it provides blood flow to the pulmonary arteries from the left or right subclavian artery via graft. So they do a graft, and that will provide blood flow to the pulmonary artery from the left or right subclavian artery. Um, the other thing that they can do is a complete repair, and this is usually performed in the first year of life. And indications for this include like increasing cyanosis, or where they develop these hypercyanotic spells. So you want to complete repair involves where they close the VSD and they resect where the stenosis is, and they may patch in some repairs they may patch across the pulmonary valve, um, making that pulmonary valve incompetent, and then um, they're going to put them on cardiopulmonary bypass and cut their chest open or do a sternotomy. So they develop this patch across the pulmonary valve annulus. So they're going to close the pulmonary valve and make that one incompetent, and then they will close the VSD and place the pericardial patch. And so that's a pretty big surgery. Um, so tetralogy of Fallot is what we call a boot-shaped heart, pulmonary stenosis, right ventricular hypertrophy, ventricular septal defect, and an overriding aorta And that's basically the displacement of the aorta over the ventricular septal defect. That's a nice little picture. I call it the boot-shaped heart. The next thing that is in your book is a hypoplastic left heart, and the hypoplastic left heart is actually a syndrome, I believe, and the hypoplastic left heart, yeah, is a syndrome. And this is where you have hypoplastic or underdevelopment of the left side of the heart. And it results in the absent or non-functional left ventricle, and the hypoplasia of the ascending aorta. And this is usually diagnosed before birth. They can see it, on ultrasound, and they'll place the infant on a transplant list early, so the surgery can be performed soon after birth. But um, the initial survival of this infant depends on a patent for foraminal valley and a ductus arteriosus. The foraminal valley is the is a little vessel between the heart and the liver, I believe. But um, yeah, and those have to stay open in order for that baby to survive, because the that's the way oxygenated blood gets to the body system. So prostaglandin E is administered to maintain patency of the ductus arteriosus. Other serious congenital abnormalities definitely are sometimes involved in this. The symptoms are, you'll see a grayish blue color of the skin, mucous membrane, signs of CHF, including dyspnea, weak pulses. You'll hear murmur. Um, you won't see survival past the first few months of life without some type of intervention. Um, the so that was the other. So you don't have a left side of your heart. The aorta is reduced in size. The blood flow to the body is supplied by the ductus arteriosus. So we've got to keep it open. And your mitral valve on that left side of the heart is also closed and atretic, meaning it's not developed. So let me pause here. Okay, some important things to kind of remember, that I may not have hit on is, of course, all in your congenital heart disease, cyanosis is not always a clinical sign. Um, we went over ASD, where you have the opening between the atria, and we went over VSD, where the opening is between the ventricle. We went over patent ductus arteriosus, which is where you have the symptoms where you have the systolic and diastolic pressure is widened, that you have a machine type murmur. The coarct of the aorta we went over is where there's coarct means tightening, by the way, just to let you know. But coarct is your characteristic symptoms is a marked difference in the blood pressure and pulses of the upper and lower extremities. What else? And we went over tetralogy of Fallot. Tetra means four, and tetralogy of Fallot, there are four defects. Stenosis or narrowing of the pulmonary artery, which decreases the blood flow to the lungs. You have hypertrophy of the right ventricle, which enlarges because it must work harder to pump blood through that narrow pulmonary artery. And you have a dextro position or right position of the aorta. Um, and so it's displaced to the right, and blood from both ventricles enters it. And then you have a VSD, which is a ventricular septum defect. Okay. Um, and your with your tetralogy of Fallot, let me just go back for a minute. Um, when venous blood enters the aorta, the infant displays symptoms of cardiac problems, and cyanosis increases with age, and clubbing of the fingers and toes may be seen. And the child will rest in a squatting position to breathe. So you'll see a lot of these kids with the what we call TET babies, where they'll be squatting to breathe easier, um, because this position alters systemic venous return. Some of the things you'll see with tetralogy of Fallot babies is feeding problems, growth retardation, frequent respiratory infections, severe dyspnea on exertion. We talked about the red blood cells of the body increase because the body says, okay, we have low oxygen, is chronic, so we're going to keep making more and more blood cells, and you develop what is called polycythemia, and meanings that there's an increase in red blood cells, and to compensate for the lack of oxygen. So that's also very, very important to know. And of course, the narrowing of the pulmonary artery will cause the right side of the heart um, to fail. Okay. Some other things, and I think that's it. Yeah. So just know there, the you'll have for tetralogy of Fallot, you'll have the paroxysmal hypercyanotic episodes or TET spells, um, and they are just spontaneous cyanosis, respiratory distress, weakness, and syncope. They can last a few minutes to a few hours, and followed by lethargy and sleep. And we tell parents, and daycare providers, to instructed to place the child in a knee to chest position when a TET spell occurs. Um, if they're not one that get down on squat and until the attack abates. But a baby, you want to put them in the knee to chest, and you can see a picture of it in your book, on page 610. Um, and the reason why I showed you the boot-shaped heart is because on the X-ray it looks like a boot. Um, and when they do a chest X-ray, and the treatment for that is, is the Blalock Taussig surgical procedure, which creates a temporary shunt. And I think next we will talk about some acquired heart problems. So hold on. Kawasaki's disease is a sometimes called mucocutaneous lymph node syndrome, and basically it's an unusual but a very serious illness, and it's classified under an autoimmune disease, and it usually affects children like less than 5 years of age. Um, there's some research out there that says it is a viral, maybe a mild asymptomatic, viral infection in children. Um, some scientists will classify it. Most of them will classify it as an autoimmune against that, an autoimmune disease. It is not clinical symptoms are make the diagnosis because the specific laboratory findings are not diagnostic. So, you can't draw a lab and find Kawasaki disease. It has to be based on symptoms. but it causes the inflammation of of your vessels. The walls of your blood vessels throughout your body become inflamed, and this inflammation will weaken the walls of your blood vessels, and you get this abnormal dilation of the walls of the blood vessels, and so sometimes you can get leads to aneurysm, or you know, and this is really bad when you have aneurysms of the coronary vessels. And we know the coronary vessels sit on top of the heart and supply blood to the coronary muscle. So this is, you know, unless we have to try to get it treated. And aneurysms can also cause thrombi to form, and which is a serious complication. But your manifestations are we see the Kawasaki disease mnemonic used. It's called crash and B, or you can think of it as crash and burn. And we see you know a sustained fever of 104 usually, that does not respond to antipyretics or antibiotics. The fever lasts more than 5 days, and you'll see conjunctivitis, which is non-purulent or without discharge, and you'll see like their lips will be very fissured, and they'll have this strawberry tongue, which is the enlarged red papilla on the tongue. The mouth will be inflamed, and the throat. Enlarged lymph nodes are often seen, in the adenopathy, cervical, and commonly unilateral. There's a rash that develops with swollen hands, and peeling of the your hands, palmar and erythromal swelling, and sometimes you'll see the peel. But this is burn, means the fever lasting 5 days or more. It's usually about 104. And they will look at a echocardiogram. Usually later on, it will be an important diagnostic tool. And I think your book says about the 10th day is when you'll start to see something on the echo that can tell you. But just the labs are not going to tell you anything, but you might see an elevated C-reactive protein, or an ESR, which is a SED rate, um, and it may or may not, but like I said, the diagnostics and the symptoms, the diagnostics of an echo at 10 days, or um, and most of the cardiovascular these symptoms that we talked about, this crash and burn, the fever, the hands, the strawberry tongue, the swollen lymph nodes, the rash, conjunctiva, um, with non-purulent. But anyway, the treatment is IVIGG, which is intravenous immunoglobulin, or IVIG. Is administered IV, of course, and this is an immunoglobulin, um, and it can prevent all these cardiac pathology, or coronary artery pathology. Um, and we give aspirin, is prescribed for antithrombus properties. Um, you know, if they don't respond to this IVIG and the aspirin, they give them a second dose, or they give them cyclosporin. Prednisolone may be used, but it's not as effective as these other things. So long-term low-dose aspirin therapy may be prescribed to prevent clot formation, because the vessels stay um, inflamed for a long period of time, making them more susceptible to thrombus, or development of thrombus. Um, and it's hard because for long term, requires this long-term therapy, um, and so children start to feel well and they won't take their medicine, and so it's a tough situation. But one of the other things she asked me to go over with you is to talk about digoxin and and with the heart disease, and you know, two nurses should check dosages on kids digoxin, or adults digoxin too. But if you ever see a single dose larger than 0.05 milligrams, or 50 micrograms, this is not going to be, it's always going to be less than that. So you need to be fully aware that you're never going to give more than 0.05 milligrams or 50 micrograms um, to a pediatric patient. So always confirm that digoxin dose, because we give digoxin in some of these cardiac cases to improve their outcomes, especially the ones that need the extra squeeze that digoxin provides. So we're talking about rheumatic fever. This is a rheumatic fever plus recurrent infection. Rheumatic fever is a systemic disease involving the joints, the heart, the central nervous system, the skin, subcu membrane, subcu tissue. And the common feature is the destruction of connective tissue, and rheumatic fever is particularly likes to attack the valves, because they're made of um, connective tissue, and it's related to beta hemolytic streptococcus infection of the throat. So in strep throat, um, it often follows, a rheumatic fever, and then the rheumatic fever causes the damage to the valves, and that's why we cover this in cardiac. But rheumatic fever is an autoimmune disease that occurs as a it occurs as a complication of untreated group A beta hemolytic streptococcal infection of the throat. Um, So your symptoms of rheumatic fever range from mild to severe, uh, and after a strep throat infection. And the symptoms are like wandering joint pains, skin eruption. Chorea is a nervous disorder, or inflammation of the heart. You may see subcutaneous nodules that may appear beneath the skin. You may have abdominal pain, often mistaken for appendicitis. Fever varies from slight to very high. Um, the one lab that we see is an elevated ASO, or which is called an anti-streptolysin O titer. Again, an elevated ASO is done to test for rheumatoid factor, or rheumatoid fever. And rheumatic fever tends to reoccur, and may tend to cause more damage to the heart. So this rheumatic fever plus recurrent infection, and it's a cross-immune response between host and the streptococcal antigen. So you get this abnormal reaction causing an autoimmune disease, and you get rheumatic pancarditis, or inflammation of the heart, endocarditis of the valves, erosion of the valve leaflets, fibrinous thickening and thickened valves, and stenosis and regurgitation. So it affects the certain valves, and here's some more symptoms of rheumatic fever, rheumatic heart disease. Fever, swollen red joints, or that migratory, what you in your book you see the migratory polyarthritis, nodules over the swollen joints, skin rashes, breathlessness, fatigue, chest pain, fainting attacks, palpitations, uncontrolled movements of facial muscles, legs, and arms. So rheumatic heart disease is basically a sequelae of rheumatic fever, consists of mitral, aortic, and tricuspid valve disease. So it affects that the connective tissues of the mitral valve, and you end up with mitral valve regurgitation, aortic and tricuspid valve involvement will result in aortic and tricuspid regurgitation. Rheumatic aortic stenosis and has never been seen below the age of 15 years, so it doesn't affect your younger group of kids. So here, if you look at mitral regurgitation, if your mitral valves are affected, I don't think she wants you to know this, but probably just know that those are the valves that are affected. But if you have mitral valve regurgitation, that means they're incompetent. So that means that the mitral valves do not meet. So this is the right side of the heart. If this is the left side of the heart, and we're going out here to the aorta. So this is the left ventricle. So right here is your valve. And so what happens is you get backflow of the blood into the atrium during systole. So because so during the contraction of the heart, you get this backflow of blood, okay? Regurg. Tricuspid valve, there's this backflow of blood into the right atrium. So tricuspid valve is affected. That's on the right side of the heart. So backflow to the right atrium, whereas if you've got mitral valve, you get backflow into the left atrium. And then with aortic valve regurgitation, here's your aorta, okay, and then this is your left ventricle. So there's backflow backwards from the aortic valve because it doesn't close, okay. So hence, you're going to have some of the symptoms associated with that backflow into the left side of the heart, and if you have chronic recurring uh, episodes. Now, you also have what is called rheumatic carditis, where it's an inflammation of the heart, and this is a manifestation of rheumatoid fever, and it can be fatal. And basically, the tissues that cover the heart and the valves are affected the same, and we look at what we call myocardial lesions called Aschoff bodies, are also characteristics of this disease. I don't think I put it on here, but Aschoff bodies are characteristic. The what happens is the heart is just overwhelmed because it has to pump harder to circulate the blood, and the heart will eventually become enlarged. So you'll see that dyspnea, exertion, and but if you look in your book, you see Jones criteria, where you have, it's called Jones: joints, obvious carditis, nodules subcutaneous, um, erythema marginatum, or symptoms chorea, which we put up here. We listed up here. Wait a minute, I think it's up here. It's here. No, it's Cossack. Right there, between those two pages. Okay, I'm going to pause right here and download this, and this way we did it in exactly an hour. Okay, so pause. All right. Oh, one more thing. I'm so sorry. Never mind. One more thing. With the rheumatic heart disease, you need to be teaching about, if someone has developed rheumatic fever or has had rheumatic fever, nurse should teach the parents about the need for prophylactic antibiotic therapy before any dental procedure. So that'll be it. All right, y'all, take care. Talk to you later. Bye.